Hello, welcome again. Dr. Anthony Gonzalez here with Miami Community Health. We're here with another important health topic. We're going to talk to you and instruct you and educate you and teach you about orthopedic surgery. I brought a colleague from Baptist Health, South Florida, Dr. Frantz Lerebours, here with us. He's going to talk to us about orthopedic surgery. We're going to cover two important topics today. We're going to cover orthopedic trauma, and we're going to cover some sports medicine. So I want to welcome Frantz. Welcome.
Tony, thanks for having me.
All righty.
Be here.
So why don't you tell us, everybody, a little bit about yourself, who you are, and what you do?
Yeah, so Tony, I'm originally from New York, Long Island, New York, born and raised. My family's of Haitian-American descent. I practiced in Los Angeles before I moved out to Miami and joined Baptist. I did my training at NYU and went to undergrad at NYU as well, and spent some time in DC at Howard University. I have a great enjoyment for being here in Miami, and I'm super excited to be here.
Right. Yeah, we learned recently that we're both of Haitian descent. You know, my mom was Lebanese, born in Haiti, and so I spent many of summers in Haiti, and of course doing missionary work in Haiti. So we were practicing our Creole before the cameras went on. So I understand you have some family in the orthopedic world as well. Is that correct?
Well, I come from a family of healthcare workers. My mom is a retired nurse. She was a med surg nurse at what used to be called LaGuardia Hospital, now North Shore in Sunnyside, Queens. My father's an ophthalmologist, and my younger sister's also an ophthalmologist. So healthcare and medicine was always kind of in the back of my mind growing up. I went to college and did like what most kids want to do, and I kind of rebelled and studied economics. And then I circled back and decided that helping people was something I wanted to do. And then I went to med school and then went in orthopedics.
Wow. Okay. And in sports, how sports played in all of your life? You've been involved in sports?
I was an athlete growing up, and when I was 15, that was my kind of first exposure to orthopedics. I broke my ankle, and I had this really great orthopedic surgeon that took care of me, and kind of was the first kind of impetus for learning about orthopedics and deciding to maybe think about it as a potential career opportunity. And then I played high school football. I was an all-league linebacker. And then when I went to med school and looked at all the different subspecialties, orthopedics is the one that really kind of stood out to me because of its affinity for, or ability to just see a problem and fix it immediately. The satisfaction of being able to see a fracture and see a deformity, line up the fracture, stabilize it, and at that time you can tell how the patient's going to do based off the post-op X-ray.
Yeah.
So to me, that was always something that was
that's something about all us surgeons. We like to see a problem, fix it, resolve it, and be done with it. You know, as opposed to like our internal medicine colleagues. You know, they treat diabetes and it's never ending. You know,
right?
So so fast forward now. Today, you're a practicing surgeon. You're here at Baptist Health, and we're going to talk about two aspects of your practice. What do you enjoy most about your practice?
So I practice both trauma and sports medicine. What I enjoy most about the trauma aspect of it is when you see somebody in the OR, you see somebody after they have a traumatic incident, you're seeing them on their worst day. It's their worst day. They either got hit by a car or they fell off an electric scooter, and you see that problem. And then the best part about it is seeing them 2 to 3 months later when they walk into your office and they're no longer in pain and they've regained their ability to walk or use their limbs, and they're able to go back and to enjoy their lives. That's probably the best part about this.
Wow. Yeah. Bring them from the brink of defeat to victory. So that's awesome.
Exactly.
All right. So let's go over orthopedic trauma. And of course, you know, for me and maybe even our viewers, understanding what orthopedic trauma, it may be simple, but why don't you just kind of redefine for us what is orthopedic trauma and what does an orthopedic traumatologist, I guess I would use the word, do?
Sure. So there's multiple different subspecialties of orthopedics, whether it be joint replacement, sports medicine. But what trauma does is it basically is the field of dealing with fractures, fractures of the extremities as well as the pelvis, and stabilizing those fractures at the time of injuries. So we deal a lot with hardware, plates and screws, as well as rods, and there's been quite a bit of evolution in how we fix fractures from 10 years ago. We're becoming a lot of the hardware and the instrumentation is much more minimally invasive. We're able to use smaller incisions, use wires and X-ray to localize how we're going to line up the fracture and stabilize them.
And so you mentioned broken bones. Do you not deal with injuries that are like broken ligaments and torn ligaments and other things that are not bones?
Yeah. So when it comes to soft tissue injuries, specifically tendon injuries, ligament injuries, things like ACL tears and rotator cuff tears, those are actually treated by sports medicine specialists.
Ah, so that's where the separation is.
Right. Exactly. So,
okay.
So sports medicine is more of a field of soft tissue injuries. I actually specialize in sports medicine as well. And sports medicine is a little bit more nuanced in that you're using cameras to access joints to repair ligaments.
Okay, so then what are the common traumas and orthopedic traumas that we see? Let's go over a couple of them and understand what are the common injuries that people come into our hospitals with.
Sure. So one of the by far one of the most common injuries that we see are hip fractures. That's probably one of the most common things in patients that are older, elderly patients who are who have osteoporosis, typically have low energy falls, fall from standing, and they sustain hip fractures. And then the other more common fractures are things like wrist fractures, distal radius fractures, as well as ankle fractures. These are the everyday community injuries that happen from trip and falls, from low energy mechanisms.
So let's go over with a hip fracture. Grandma's at the house, grandma trips, falls, and you're the child or you're the grandchild and you're there with grandma. How do you know that there's been a hip fracture? You know, you're not a healthcare provider. You can't do an examination. Right. How do I know I just get grandma back up and keep her pushing, or I have to get her to the ER? Not everybody who falls has to go to the ER. Right, so can you give us a little bit of insight of, and educate us on who should go to the ER?
Sure. So one of the most common tell signs of a hip fracture is that the leg itself actually becomes short and externally rotated. So when the hip breaks, there's different muscles that pull on the fracture fragments. And one of the things that happens is that the foot itself will start to turn outward and then the leg will shorten. So if you see that your family member falls and they have this type of deformity, you can assume that they have a hip fracture.
Right.
If you're not too sure, one of the things that you can do is do what's called a log roll, where you basically take the limb and roll it like a log. If they're in a lot of pain at that point, you can assume that there's likely an injury to the hip, and then you should call 911.
All right. So if you see grandma on the floor, the leg is shorter and out, then gotta call rescue and put her on a gurney and get her. Okay. Exactly. So grandma ends up in the ER with a hip fracture. Everybody with a hip fracture has to go to the operating room?
So I would say a majority of them, 99% of them have to.
Okay.
The thing about hip fractures is that it's really important to get them fixed right away, to stabilize them right away, because that actually has an effect on their outcome as well as their mortality. When you're older, when you're elderly patients, when they can't mobilize and they're bedridden, or they can't mobilize, they start to get complications associated with we call recumbency, by not moving around. So they start to get blood clots, they start to get pneumonias, they start to get bed ulcers. So typically we stabilize the fractures right away so that we can get them up and moving to prevent a lot of those complications.
And so right away, it's not like to the operating room in the middle of the night. It's like the next day or 2 days, or what is right away? Because for me and for everybody else, right away is different, right?
Right. So really, as soon as possible. One of the first things we always try to do is we try to make sure that they're medically optimized, making sure that their primary care doctor or the hospitalist make sure that they're safe to undergo surgery. But a lot of the research has shown that if you fix the fracture within 24 hours, they are less likely to get a lot of the complications associated with not moving around, whether it's a urinary tract infection or blood clots. So typically, as long as it's safe to have surgery, we try to fix it right away.
All right. And so let's talk to us about a little bit about the surgery. What is done in very simplistic terms for a hip fracture? Well, how do you fix that?
Sure. So there's different type of hip fractures. It all depends on the location of where the fracture is in the hip. So there's if you look at the hip, the anatomy of the hip, there's the ball, and then there's the neck portion, and then it extends into an area called the inner trochanteric region. So if you fracture around the neck, typically that would require an actual arthroplasty. Arthroplasty is the medical term for a hip replacement.
Wow.
So when you fracture at the neck, it actually cuts off the blood supply. So at that point, even if we were to go and fix the fracture, the actual fracture wouldn't heal because the actual blood supply is cut off. Now, if you fracture a little bit farther down in the inner trochanteric region away from the neck, at that point, we can actually preserve your head, and we fix it with, we place a rod inside the bone and a screw that actually interlinks with the rod. Because the rod is inside the bone, it actually shares load with the bone. We can get you up walking right away.
And so what is the recovery for some of these type of operations? What are we looking for? Grandma fell, ends up in the ER, has surgery with you the next morning after she's been medically optimized. Grandma's going home when? Well, how long? When is grandma playing sports again,
So, everybody's different because obviously there's a pretty big spectrum of people's activity level, especially with the elderly population. So typically we know that whatever your pre-injury ambulatory status was, basically how much you were walking before will dictate how quickly you will get up and walk afterwards. So if you're a very mobile person and you are active and you sustain this hip fracture, you're more likely to get going pretty quickly. You'll probably be in the hospital for about 1 to 2 days before being transferred to rehab. Now, if you were somebody who's, let's say, ambulatory with a rolling walker, or let's say you're wheelchair bound, you're less likely to mobilize as quickly. So you might be in the hospital a little bit longer before being transferred to a rehab. So that usually depends.
All right. So we've learned that if grandma falls, an elderly person in your house falls, check their hip, check their leg, their rotation, see what's happening. If their leg is shorter, get them to the hospital. And of course, surgery should be done relatively soon. And we've learned a little bit about that. Now, some of the other fractures or some of the other orthopedic traumas you talked about was wrist fracture and ankle fracture.
Right.
And I would assume, that if you break your arm, you're really going to see a deformity. Or if you break your ankle, I've actually seen that like on maybe on TV and stuff like that. It's pretty cringing.
Right.
You see the leg turn the other way and so forth. Right. So is that what happens? Is that really what happens? Like, if you broke something?
Yeah, for the most part. I mean, ankles are pretty obvious. Usually there's, like I said, there's different flavors of them, but most of the time with ankle fractures, you're when you have an unstable ankle fracture, you're not going to be able to really bear weight right away. But sometimes, I would say half the time, the ankle actually dislocates, so you can see an immediate deformity. With the wrist, same thing. The wrist typically the wrist, you'll see a deformity where the hand bends backwards, and there's what we call dorsal angulation. I know if this is a little cringeworthy for people, but usually you'll see a deformity.
All right, so then you have to go to the hospital for those.
Yeah. Exactly.
Okay, and those people need surgery?
Not all of them do. So with wrist, with wrist fractures, oftentimes you could do what's called a closed reduction, where you basically press on the wrist to recreate the deformity and realign the wrist, and you place them in a splint. As long as it's not the fracture doesn't extend into the joint, and it's a stable fracture pattern, meaning that there's two big fragments that can oppose each other and line up pretty well, we could treat that in a cast, actually, and oftentimes that'll heal with good alignment, and you won't have any long-term implications. But I would say about half of ankle fractures need surgery. There's different types where the ankle the talus bone that sits under the tibia can be unstable and can shift slightly. And if it heals in that shifted position, you actually get rapid degeneration of the cartilage, and you get arthritis later on. So, So those are typically, we always recommend fixing.
Well, orthopedics is complicated.
Yeah,
I thought it was simple.
It's not any more complicated than general surgery.
All right. So then, my nephew fell. Skateboard accident when he was like a little teenager or whatever, and he ended up having to have surgery and plates. So who has to have plates in their arms when they break their arms or their forearms?
Yeah, so typically it's the fractures that are what's called we use the term comminuted, where they're in multiple pieces, where there's not good opposition between the two fracture fragments. So even if we line it up, because there's not enough surface area for the two bones to rest against each other in a splint to stay stable, those are typically the ones that will actually use the plate. The plate is essentially an internal splint, where it's just holding things in place to allow your body to heal. Once your body heals, the hardware is essentially useless.
Hey, I didn't ask you this on the first, in hip fractures, but when I was in residency, well, actually, probably as a student, I think, and we did ortho trauma at Jackson because I trained here at Jackson. Everything was just X-rays, X-rays on the board. Are you guys are still using X-rays, or you guys are more advanced now, or everybody's getting MRIs, or what are the testing like?
Yeah, so X-ray is still the standard. What's great now is actually we don't have to throw
Yeah,
them up
put them
now.
up.
They're
Yeah.
digital.
You see them on your phone.
Yeah, exactly,
Yeah.
exactly. But when I was a resident back at the VA, we used to have to, fetch a lot of those X-ray jackets, and that was quite cumbersome. But X-ray is still the standard.
Okay.
Well, now we have CT scans, which have become give us a lot of information. And what's really cool now with the CT scans is they use different algorithms to actually give you a 3D rendition of a lot of these fracture patterns, which gives you a ton of information when you're pre-op planning, as well as when you're deciding whether or not something needs surgery.
All right. So we really talked about the three most common, let's say, orthopedic trauma, which is the hip fracture, the wrist, the ankle. We really taught our guests when to come to the hospital, and then, of course, come to a Baptist Health facility. Even if you're at a smaller facility, if you need, more advanced care, they'll get you to a bigger facility, and you get surgery, maybe not, maybe a splint to get it cared. Anything else we need to add or educate our community about orthopedic trauma or orthopedic injuries?
Yeah, so I would typically just say, the thing about fractures period where it's important, even if you think you have a fracture, that you need to seek attention. After about 2 weeks, fractures start to heal and consolidate. So let's say if you do have an ankle fracture and let's say, I've seen this where people put it off.
2 weeks?
And they put it off after 2 weeks, and then they
Wow.
come in and we see these
And
fractures.
you can walk around for 2 weeks, or
You'd be surprised. Some people just stay home. And this is something that we saw a lot during COVID, where people were just avoiding going to the hospital. They had these injuries and they would just stay in bed, and they just avoid going to the hospitals for fear of either catching COVID or just not wanting to go out.
Yeah.
And they would come in, and these fractures would start to heal in these malaligned positions. And at that point, it becomes very difficult to really recreate their anatomy to fix them anatomically. So I would say that if you do have an injury, you do have a fracture, definitely seek medical attention. Do not wait longer than 2 weeks.
Yeah, I think the simplest thing is if well, now we're not dealing with the COVID like we were in the past. We dealt with the same thing in general surgery with regard to people home with bad gallbladders, perforated appendixes, and just coming in a mess.
Sure.
But, go to an urgent care. They can get a simple x-ray and know whether you have a fracture or not. So I think you can do that as well. All right. So let's get over to sports medicine. Let's talk a little bit about sports medicine. And sports medicine, kind of a very big term, very broad term. But, for an orthopedic surgeon, what does sports medicine really mean?
Yeah. So sports medicine, most people think sports medicine is really the treatment of treating athletes, but it's actually a subspecialty, like we talked about earlier, that involves dealing with soft tissues. So ligament as well as tendon injuries. So ligaments are basically a tissue that connects bone to bone, or tendons connect muscle to bone. So tendons, things like your biceps. Your biceps has a tendon attachment on your forearm. When you flex your biceps, it allows you to bring your arm up, as well as we call supinate, turn your hand out. Whereas a ligament provides stability to a joint. So one of the most common ligaments that people hear are the ACL tears. So the ACL is very important in providing stability to your knee. It allows you to jump, pivot, change directions without the two bones shifting. So a lot of sports medicine deals with stability of joints. So if you're dislocating your shoulders, we typically will repair the labrum. And what's cool about sports medicine is that a lot of it is dealt using arthroscopy, where we don't have to make big incisions, where we can use cameras and small instruments to essentially recreate or reconstruct torn ligaments or tendons.
All right, so let's talk about some of the common injuries. You already mentioned ACL, and I don't know if that is one of the more common ones. Let's go over some of the common ones and what people will feel, and then of course what the evaluation and the treatment is like. So, what are some of the common sports injuries or sports medicine diagnoses and conditions that you usually see?
Sure. So let's talk about ACL. So ACL is a very common one. You see a lot in sports like basketball, sports like soccer, especially on turf. One of the things with playing on turf is that it doesn't give way. You're not able to decelerate when you're, let's say, playing on grass. So you stop quickly. So what happens is that you have what we call a non-contact pivoting injury, where you'll stop quickly and your knee will essentially kind of rotate inwards, and then you'll feel a pop. And the interesting thing about ACLs is that you'll have that pop, you'll fall to the ground, you'll have some swelling in the knee, but a majority of players are able to get up and start walking off the field right away, even after an ACL tear.
Are they able to play right there? No,
they're not
they
able
won't
to play. They won't play.
Okay.
But you're actually able to get up and walk off the field. And you see it all the time in football or basketball. Players fall to the ground, they grab their knee, and they're able to somewhat walk off the court or field. But one of the symptoms that you'll feel is that whenever you, let's say, step and change directions, you'll feel shifting and pain in the knee. And that's kind of one of the tell signs of having a torn ACL.
But what about in the everyday life? Those guys like me and anybody else who's not playing, soccer or basketball at that extreme level, what type of things could happen that we could tear an ACL?
Things like falling from a certain height. So let's say you're on a ladder, you fall down, or you fall downstairs, or certain car accidents can cause it. Basically, anything that would cause a twisting injury to the knee can essentially tear your ACL.
All right. So if you have that concern, we go see someone like you, as a sports medicine doctor, somebody who has that experience. What is the evaluation like? What's the treatment? What's the evaluation, investigation, and of course the treatment?
Sure. So first off, we'll start off with some basic x-rays, take a look. Well, the most important thing is doing a physical exam. There's a few tests that we could do during the physical exam to test the stability of your knee. If those exam tests are positive, at that point, we'll get an MRI. An MRI is pretty much the gold standard.
Now, the ligament, the ACL is inside the knee, right?
Exactly.
It's inside. It's not a ligament on the outside of the knee.
Exactly.
Right.
It's right in the center of the knee. It actually, ACL stands for anterior cruciate ligament. The cruciate, it forms a cross, basically.
And there's a posterior cruciate ligament.
Exactly.
But how come that one never gets injured?
It's less torn. It's usually less commonly torn.
Okay.
Just based off the mechanism. It's a much larger, stouter ligament, and you typically need a significant force to the front of your knee to push your tibia bone backwards to actually tear it. So it's not something a mechanism that we commonly encounter.
Okay. So you get an MRI, patient's got a ACL, anterior cruciate ligament injury. What happens now?
So at that point, you have an ACL tear, and then we have the discussion with you. So not everyone needs to have an ACL reconstruction. It depends on your age, your activity level, and the type of things you need to do. So if you want to walk in a straight line, or even run in a straight line, or ride a bicycle, you don't actually need an ACL. So patients that are older, patients that are, let's say, older than, let's say, 40, 50 years old, who have an ACL tear, they don't always need to necessarily get that ACL reconstructed. One of the things happens is that as we get older, we actually lose our flexibility. Okay. Our skin gets drier, our soft tissues get drier. We don't have the same flexibility that we had when we were younger. And that lack of flexibility actually gives us stability. So patients who are older than 40, 50, even if they have a torn ACL, they may not have those instability episodes where they go and turn their knee and the two bones shift. Now, younger patients do. Younger patients are much more flexible, and they also they participate in a lot of activities that require an ACL. Like me and you, I don't play intramural sports anymore. So if I tore my ACL, I don't know if I necessarily would need to get it reconstructed, because I don't do a lot of jumping, pivoting, cutting, and changing direction like I used to when I was younger.
Yeah, but I'm taking offense that you're calling me old because I'm older than 40 or 50. Come on, man. All right. So you may not need it fixed. You may not need surgery. And then if you do need surgery, what is that like? Is that part of those, like the lap, what I call laparoscopy? You're doing arthroscopy with little cameras and stuff?
Exactly. So one of the first things you need to do, so you need to get over the initial inflammation and swelling of the injury. So we will typically send you to what's called prehab. So rehab before surgery. So, and that the goal of that is to get your range of motion back, because they found that if you do an ACL reconstruction on somebody who has significant swelling and stiffness, their pre-surgery range of motion of their knee will dictate their range of motion afterwards. So, and they found this out because in Vail, Colorado, They were literally fixing everyone's ACL as they came off the mountain. And they found that a lot of those patients had significant stiffness afterwards. And they published that paper showing that you have to regain your range of motion before we can actually reconstruct your ACL, because if not, afterwards, you're going to have a really tough time getting your range of motion back.
So through those little holes in the camera, you guys just reconstructed, and you just sew that ligament back down, or you get ligament from somewhere else?
Yes. Unfortunately, we can't use your own ligament anymore. They've tried back in the 80s to try and sew your own tissues together, but it actually doesn't heal. So we actually have to reconstruct your ACL. So what that means is that we either take tissue from you, from another place in your body, or we use cadaver tissue to essentially replace your ACL. We place drill holes, drill tunnels in what we call the footprint of where the ACL is. And then from there, we use the ligament from either yourself or a cadaver to give you a new ACL.
Wow.
There's some pretty cool new techniques and new methods of fixation that have really minimized the scars and also improved the overall fixation and stability of ACLs. ACLs is one of the most studied subjects in sports medicine, and it's evolved quite a bit, even over the last 10 years.
And athletes, not only us, but people, weekend warriors, but real athletes can get back and go back and do all athletic sports.
Yeah. So the return to sport after ACL reconstructions is really good, and that's why you see a lot of your favorite professional athletes that even though they tear their ACLs, they're able to come back and play at a high level afterwards. I remember that one time Adrian Peterson tore his ACL the following year. He almost broke the NFL rushing record.
Incredible.
So, yeah, so he's one.
You guys are doing a great job.
Yeah, exactly. So a lot of so ACLs have come a really long way.
All right. And so what is another sports medicine injury that you see commonly in your practice?
So ACL is something we see obviously in younger patients. So even in older patients, we see rotator cuff tears, very common in patients over the age of 50 years old, or even in patients in their 40s. The rotator cuff is basically a cuff of tissue that sits on the top of your shoulder and allows you to bring your arm up in multiple directions. It's a very commonly torn tendon. Actually, Harvard did a study. They did a population study where they looked at how many patients, what's the incidence of rotator cuff tears in patients over a certain age. And they found that after 55 years old, around 30 to 40% of the population have rotator cuff tears.
And how will you know at home if you have a rotator cuff tear?
So one of the more common,
I'm worried now. You're making me nervous.
No. One of the more common signs and symptoms is pain, obviously.
Okay.
Pain at night. The rotator cuff becomes very painful at night. It wakes you up in the middle of the night, 2, 3 in the morning, keeps you up. And then your inability to bring the arm up. Okay?
Oh, okay.
And even when you bring the arm up on the way down, it actually hurts. And you'll see a lot of patients kind of do this with their arm when they bring it down. And that's typically a sign of impingement or rotator cuff pathology.
And then you need what type of testing? An MRI?
Yeah, exactly. So MRI is the gold standard as well. MRI is great for looking at soft tissues and seeing how much it's torn. Now, not every rotator cuff needs to be fixed. Okay, there's different types of cuff tears. So there's what we call a full thickness tear, where you tear it all the way through the tendon, and depending on the location as well as the shape of the tear, you don't always need surgery. And then there's what we call partial thickness tears. So the rotator cuff, it's when you look at it from the side, it's almost like plywood. When you look at it from the side, there's multiple laminated layers. So oftentimes you'll tear maybe 1 or 2 of the layers, and the rest of it is intact. Those don't need to go to surgery right away. Oftentimes you still have a lot of function, but you'll have a lot of what we call bursitis. You'll have inflammation around the area of where the rotator cuff moves. And oftentimes physical therapy and maybe injections can help you get over the pain and help resolve a lot of those symptoms.
And then if you need surgery, how is surgery? Is it you guys doing it arthroscopically as well?
Exactly. So we basically place cameras inside the shoulder, and then we basically use these devices called suture anchors, and we basically use instruments to weave those sutures through the rotator cuff and then compress the tendon back down to the bone. And that's the suture anchors, as well as different biologics have really kind of pushed the success of how rotator cuff tears do.
And that's changed over the years because, you guys have been able to, again, with pitchers, another example, right? I mean, rotator cuff injuries were big with pitchers, and that used to be the end of it all, right? If a pitcher had a rotator cuff injury, he'd never be able to pitch again. And now, of course, you guys, that's like almost common practice, and they come back. Is that right?
Exactly.
Yeah, that was famous. Who was that? Tommy John.
Tommy John.
Tommy John made that famous.
Exactly, he did. I trained at Curl and Job, where Tommy John surgery was basically
performed
and innovated. And
wow,
and it was really interesting to learn from a lot of those guys out there, and how that whole story came about, and how Frank Job was able to really change the face of baseball and change pitchers' careers.
Wow. So if you're a weekend warrior softball pitcher and you're having problems with your rotator cuff, Franz will fix it for you and make sure you can pitch softball again, right?
We'll do our best.
All right. So we've learned quite a bit today about orthopedic surgery. We've learned about Dr. Lerebours here, Frantz Lerebours with Baptist Health Orthopedics, and he's talked to us about all the issues about trauma, dealing with trauma, broken bones, broken ligaments. We've learned about the difference between orthopedic trauma as well as sports medicine and injury of ligaments as well. So, if you are having pain, and let me tell you, I've never broken a bone, thank God, but I've had some injuries. Orthopedic injuries hurt. They hurt. I was surprised how they hurt, but definitely, seek attention and see at least the urgent care or the ER. And if you need specialized care, definitely, Dr. Lerebours and his team will help us. So any parting words of wisdom for our viewers in the world of orthopedics that you think would be helpful for those people out there, with possible orthopedic injuries?
Yeah, I would say just, if you have anything that's really lingering or bothering you, definitely seek attention. Call your primary care doctor, call your local orthopedic surgeon. Don't wait too long or put off injuries, because oftentimes the longer you wait, things become much more difficult to fix. And then I would say be careful on electric scooters. That is something that we see quite a bit in the community. So definitely be careful on those.
Yeah, that's like all around the world.
Around the world.
That is incredible. There's a lot of injuries with that, huh?
A lot of injuries with that. Those things, they take, because they're electric, they take off extremely quickly. So oftentimes a lot of patients are falling off those things.
Wow. Okay.
Yeah.
Well, get care immediately. Like all medical conditions, if you got cancer, you got to get care early. If you have an infection and an abscess, a perforation in your abdomen, you got to get care. And if you have an orthopedic injury, get care early as well. So I want to thank Dr. Lerebours, Frantz, for being here with us. Thank you again for our viewers for participating. And once again, Dr. Anthony Gonzalez with Miami Community Health signing off. Have a great day and be healthy out there.
Thanks, Tony.